Good evening, everybody. Welcome again to the National Fellow Online Lecture Series. This series is sponsored by AMSSM Fellow Online Educational Subcommittee, the AMSSM Educational Committee, as well as the AMSSM Fellowship Committee. Our speaker today is Dr. Laura Goldberg, and she will be speaking on pediatric overuse injuries. Next week, we will be having ECG interpretation. The speaker will be Dr. David Siebert, and I will be moderating that session. Remember, the goal of this talk is to serve as an adjunct to your individual program, educational programming, to provide fellows with direct access to educational experience with experienced AMSSM members and at times invited speakers. It's also to assist in CAQ exam preparations. Couple of housekeeping rules as usual. Please remember to mute your device microphones and turn off your video. Submit questions to the chat function and include your name and the program if you wish to. The moderator, which is myself, will ask the questions at the end during the Q&A sessions based on the questions that you submit. And after the program, if you have any feedback, please feel free to let us know. Just as a reminder, there's an AMSSM Library of Sports Ultrasound Pathology. We are collecting different ultrasound pathology cases. Please feel free to reach out to Kirsten, whose email is above, or click on this QR code to get more information. Any attending or training can submit this, and we're looking for common as well as rare pathologies. Within the past month or so, we actually having cases on a weekly and sometimes monthly basis that we want you to submit. So we'll specifically ask you of a particular pathology and feel free to submit those. And these are cases that you can also add to your CV for publication in the future. So before we get started, I'd like to introduce Dr. Laura Goldberg. She's a pediatric sports medicine specialist in the Division of Sports Medicine and a clinical assistant professor of pediatrics at Case Western Reserve University School of Medicine. Dr. Goldberg completed a primary care sports medicine fellowship in Cleveland Clinic in Cleveland, Ohio, where she practiced adult as well as pediatric medicine until she joined UH Rainbow Babies and Children Hospital. Dr. Goldberg is a team physician for Oberlin College, Lake Ridge Academy, where she provides event coverage for multiple sporting events. And she's the lead team physician for University Hospital running program. She serves as the medical director for the Cleveland Marathon for nearly a decade and continues to provide physician coverage for these races. She has served as previous team physician for multiple professional teams, including Cleveland Browns, Cleveland Cavaliers, as well as Cleveland Indians. Thank you, Dr. Goldberg, for speaking today. I'll stop.
All right, so talking about pediatric bone anatomy, like adults, we have the bone shaft, the diaphysis, that provides the strong support. And we also have a metaphysis, but in the pediatric bone, it is divided into multiple pieces. You have the epiphysis, which is the joint side of the physis. And then you have the physis, which is an area of primary growth. And it's consisted of hyaline cartilage and is responsible for the long bone growth. When you see it on an x-ray, it's a radiolucent line, and it differentiates the epiphysis from the metaphysis. We also are going to talk about apophyses, which is a secondary of growth or site of a tendon and ligament attachment. So when we are speaking about osteochondroses and osteochondritis, we want to really differentiate kind of what they are. So osteochondrosis is sort of an umbrella term. It's any abnormality of the epiphysis or the epiphyseal equivalents during the later stages of enchondral ossification. So it happens in growing bones. It has to do with necrosis due to loss of blood supply, and then the revascularization and the repair that happens. Generally, we see these as more smooth, sort of wispy or diffuse, not like a chunk taken out of it, which we see in osteochondritis. So osteochondritis is more of a progressive version of osteochondrosis, so the damaged bone and the overlying cartilage may go on to separate. This also can happen in adults as well as kids. It is common in the transition from the juvenile blood supply, where it's perichondral, shifting to a more mature blood supply of the subchondral bone that comes from the medullary blood supply. So what happens then is you've got these kids that are being super, super active, they're getting micro trauma, and the blood supply is shifting and it hasn't quite matured. And so you get avascularization due to micro trauma. That is one of the reasons we think that it happens more commonly in young athletes. It typically affects the articular surface and it looks like a bite is taken out of it. It's a more distinct lesion with irregular edges. And again, we're not really clear what happens. We think it has to do with loss of blood supply. We think it might have to do with microtrauma. There are probably other etiologies as well. When we look at the x-ray on the left, I was talking about the sort of wispy aspect of an osteochondrosis, whereas sort of generalized loss of blood supply, whereas more of a bite out is taken in the osteochondritis that we might call osteochondritis dissecans. It looks more like a bite. So osteochondrosis can happen anywhere where there is growing bone. Most of them are self-limiting. And again, just like, in all the different areas, we don't know what happens, but we think the end result is there's loss of blood supply to that area. We're going to go over some of these and the sort of pitfalls to not miss. So when we're talking about the foot, in little kids, 3 to 7-year-old generally come in with midfoot pain. You get an x-ray and you might see nothing where their navicular is supposed to be, or you might see little speckles, or you might see kind of an irregularly shaped one, and it's right where they're sore, and you don't know what it's supposed to look like because they're 3 and their bones are all kind of still cartilaginous and you can't see anything. So taking a contralateral view, you might see that on the other side, they have a normal navicular and you can compare them. So this is really important to see because it is self-limiting if it's treated. Same thing with Freiberg's. Different area, it's more, and also different growth time. It's typically in the second or third metatarsal head. It happens a little bit later in life. Again, loss of blood supply. Patients present with pain right in that area. You don't always see changes on x-ray initially with these. If they're not treated, then they will go on to progress and you will see the x-ray changes. So having sort of a heads up and thinking about them and treating prophylactically is helpful. Generally, a couple of weeks in a boot, get the symptoms to calm down and they can get back to their normal activity. When we talk about the apophysis, which is the secondary center of ossification, it's where tendons attach to the bone. So the muscle becomes tendon, attaches to the bone, then there's the physis, and then the metaphysis. So the problem is that you can have an acute injury where the tendon yanks on that growth center and causes sudden onset of pain, swelling, bruising. You can have a more chronic pulling where it can cause inflammation and changes in that physis just from the repetitive stress. Generally, both of these situations, they present with a limp or worsening with activity and improvement with rest. There are some areas that we all hopefully are familiar with, but in the heel is a growing area that we see, especially in 9 to 12-year-olds. I think of, any youth soccer player comes in with foot ankle pain. First thing I ask is, can you point where it is? Does it hurt more when you're running? Most commonly, they're going to say it's in their heel. Sometimes they'll talk about the pain projecting up towards their ankle a little bit. Typically, they're worse barefoot or in cleats. It's typically intermittent, worse with activity, improves with rest, but they can go on to have constant pain that's causing them to have a limp. I find most patients will be tender right on that calcaneal apophysis, or if they're not, they'll say, but that's where I normally hurt. And really, it is just like some of the other areas we're going to talk about. When you push on that growth plate, they hurt. It's a clinical diagnosis. You do not need an x-ray unless they're not improving. And very rarely do we get further imaging unless, again, you've treated them and they're not improving. Another area of apophysitis in the foot is on the base of the fifth. This one is a little bit less common, and oftentimes when you see them, they'll present with kind of swelling at the base of the fifth, intermittent pain, improves with rest, worsens with activity. But the history here can really help you before you even get an x-ray. Number one, what age are they? Do they, still have open growth plates? Are they in a state of growth? Do they have acute onset, and was there any sort of injury? And also, did it happen over time? Are they a runner and it gradually progressed? Because that is going to dictate sort of where we go with thought processing. So in the top right here, you can see there's a little bony fleck that is parallel to the metatarsal. That is your apophysis, your growth plate. And the peroneal tendon attaches there, gradually pulls on that and causes apophysitis. And the bottom right picture, you see that that growth plate is there, the apophysis, but you also see a line that is perpendicular. And that is an acute avulsion fracture from the peroneal tendon pulling on the base of the fifth and causing an avulsion fracture there. On the bottom left, you see a little bit more distal on the fifth metatarsal, a perpendicular fracture line consistent with a stress fracture. So history helps you. These are all treated very differently, with the acute avulsion fracture and the apophysitis less concerning than the stress fracture that you might go on to treat surgically. In general, when we are talking about apophysitis treatment, it is a decreased irritation inflammation treatment. So you might start with scheduled NSAIDs, ice, activity modification. If they're limping, I will put them in boots to restrict their activity. And for the heel, I will put them in gel heel cups. For gymnastics or barefoot athletes, they do have these things called cheetahs. And basically it's an ankle sleeve with the heel cup put into it. If they're having prolonged episodes, or they're having, you just can't seem to get them better, I send them to physical therapy really to look to see, is there a mechanical thing? Are they really a heavy, heel striker? Do they need to learn to run better? Oftentimes, though, these are self-limiting if we treat them with, activity modification, ice, and anti-inflammatories. Activity modification is probably the hardest thing to get the kids to do. And sometimes that's why I put them in a boot, is to have them take it seriously. So we are talking about these apophyses that are attached to by tendons that are attached to muscles. So the muscles contract and they yank on that growth plate and they cause damage. So the important thing to realize about this is that all of it is a traction injury, whether it's acute, it's chronic, or gradual, but the injury mechanism is the same. So it's really important to be careful about when you're treating these, that you tell them to not stretch. Because again, when you stretch, you're pulling that muscle that's pulling that tendon that's pulling on the growth plate. So these are just a picture of an MRI that shows the growth plate lit up and the tendon is not. Osgood-Schlatter, that patella tendon is attached to the tibial tubercle. And if they're doing a lot of quad stretching, the quad muscle becomes the patella, becomes the patella tendon, which is pulling on that growth center. You're just going to aggravate it again and again. So when we think about typical 12-year-old male basketball comes in with bilateral knee pain, most of us are immediately going to be thinking about some sort of apophyseal or growing pain type of injury. So this one presented with bilateral knee pain, worse with running and jumping, improves with rest. Physical exam reveals full range of motion, no joint effusion, tenderness of the distal patella tendon insertion with mild swelling and enlargement of the tibial tubercle. Pain is reproduced with resisted leg extension. What is the most likely diagnosis? Well, if he was 20 or 30, I might say, oh, well, it could be patella tendonitis and it's just distal insertion. Pes anserine is not at the tibial tubercle, so that's not it. Chondromalacia patella is underneath the kneecap. Could it be? Sure, but typically they're not going to be tender at that tibial tubercle, and Perthes is in the hip. So Osgood-Schlatter is what we're talking about. And it's just that pulling on that tibial tubercle that causes fragmentation of that tubercle and inflammation and irritation of that. So Osgood-Schlatter is apophysitis of the tibial tubercle. It is more common in boys. The reality is you can see it in both sexes, typically there is a parent that has had it. When they come in and they complain of acute onset of pain, it can be Osgood-Schlatter. They could have fallen on their knee and it irritated it acutely. They could have run in a game and been really tired, and all of a sudden it flared up, so it kind of presents acutely. But most of the time when they come in and it's like pretty acute onset pain, swelling, difficulty extending their leg, you want to make sure that you're looking closely that it's not actually a fracture of that tibial tubercle. It's less than 1% of pediatric fractures, but it is an important one depending on how extensive that fracture is. So when you're approaching skeletal maturity, the closing of the physis happens from posterior to anterior and proximal to distal. So you have more areas that are likely to injure. So secondary center is at greater risk of injury in the older kids, whereas your younger kids, you're going to have, more likely to just have Osgood-Schlatter. But as they start to get, older and that growth center is starting to close, the force that's going through it is more likely going to cause a fracture. Typically happens through concentric contraction of your quad through jumping or eccentric contraction of quad during forced knee flexion. I have been fooled by having kids come in and have an injury that happened like they were jumping and they landed kind of in a bent knee position. Their knee flared up. They were able to keep playing. They were limping when you ask them a little bit. These are 12-year-olds who are getting through their basketball game. They come in, they're walking in with a limp, their tibial tubercle's a little swollen, but gosh, they seem a lot more sore than what you would expect for a Osgood-Schlatter. Most of the time, I am not putting Osgood-Schlatter in an immobilizer. Most of the time, I'm not putting them on crutches. But if somebody is significant limping and they cannot extend their leg against resistance, you want to be concerned about a fracture. And so therefore, I am going to be a little bit more aggressive and protective, put them in an immobilizer, maybe put them on crutches, and follow them up much more closely. Osgood-Schlatter in an immobilizer should calm down within a few days. If it is a fracture, it's clearly going to take a lot longer. So key factors to think about are extent of swelling, sudden onset of pain, and limping, as well as an extensor lag. If you have an extensor lag, then you're thinking of a more significant tubercle fracture, and it might extend actually into the tibial plateau. When you have type 1, we can treat those non-operatively, but as they start to get more displaced, then we need to have evaluation with an MRI and also surgical consideration. So most of the time you can see these on x-rays because you'll see changes in the tibial tubercle, but you may only have anterior swelling if it's more of a type 5. So if you look at type 5, it's shearing off the periosteal lining, so you're not going to actually see it, but they are going to have a difficulty with extension because the fracture's through there. So you kind of need to use your clinical history plus your exam. If the injury was significant enough that they have significant swelling and pain, you're concerned for any sort of arterial injury, you might have to do an arteriogram. But usually you're basically evaluating the extent of the fracture. And if it's not obvious, you would start with an MRI. If it is obvious on x-ray, go ahead and get a CT to look for extension into the joint. These need to be immobilized for 6 weeks. And if they're more than 2 millimeters displaced, they are going to need surgical consultation. Switching to the other end of the patella tendon is patellar apophysitis or Syndig-Larsen-Johansson syndrome, which is another traction apophysitis that's often gradual, but as well can be acute. And these tend to be a little bit less obvious than Osgood-Schlatter. They don't get that swelling or nodule that you might see at the tibial tubercle, but they might have some diffuse swelling around there. Typically, they're point tender right at that lower pole at the apophysis. They typically have some pain with leg extension, but it's intact. And you may or may not see fragmentation. It kind of depends on how long it's been going on and the stage of development. So this is a clinical diagnosis predominantly. Now, if they had a severe injury, like they had no pain whatsoever, and then they developed sharp pain, difficulty with leg extension, and swelling, you want to make sure that you're not missing a sleeve fracture. So one way you can look at that is when you see the fragmentation at the inferior pole of the patella, you want to make sure that it is perpendicular or sort of rounded at the inferior pole. A sleeve fracture pulls a piece of bone off, and it looks like a piece of bone parallel to the patella. So this is actually exact opposite of what we see in Island's. So in this case, parallel is bad. We don't want that. What happens basically is that the patella tendon pulls off a chondral part that you can't see and a bony part that you can see. So all you're seeing on the x-ray is the bony part, but the dangerous part is the extensor mechanism is not intact and there's cartilage removed in the patellofemoral joint. So you need to have a suspicion for this. And typically, you're going to see somebody that has pain with extension or difficulty with active extension, especially against resistance. And they're likely going to have bleeding within the joint. So they're going to have some joint swelling. These need to get surgically referred and oftentimes an MRI on the way to the referral. If it is non-displaced and their extensor mechanism is intact, you can treat these with a long leg cast non-operatively, but unless you're comfortable treating them, they should be treated by a surgeon or someone that's familiar with them. So shifting gears a little bit, we've been talking about apophysitis and sort of mimickers of those. Osteochondritis dissecans is most commonly in joints in children and adolescents. It can be in older people as well, but thought to be post-traumatic, possibly thought to be vascular. It is a loss of blood supply to the bone under the cartilage, and oftentimes you'll get a little separation of that bone, plus or minus separation of the cartilage. Depending on the stability of it determines what the treatment will be. One of the most common sites is the lateral aspect of the medial femoral condyle. It does also happen in lateral condyle, but 70% of the time it's in the medial. You can see it in the elbow, ankle. Those are the most common sites. Typically, it's an insidious onset of pain. It may have recurrent joint swelling. They may have a click or a lock or sort of a catching sensation. On x-ray, you may or may not see anything, but typically you're going to get that sort of ragged edge view with a kind of bite out of appearance. The important thing to remember is that you have to get appropriate x-rays. So if you get an AP on a lateral and you think this kid has Osgood-Schlatter, comes in with anterior knee pain and soreness, and they're tender on the tibial tubercle, and they have some catching and locking and swelling, you probably should be thinking a little bit more and not just at Osgood-Schlatter. So you want to make sure you get the right x-rays. I always get 4 views, AP, tunnel, which is what we're looking at here, which shows the notch view, which shows a more posterior aspect of that femoral condyle, which is the more common area that we see the OCDs. So you've got your AP, your tunnel, your lateral, and on the lateral, as you can see over here, sometimes you can see a little sclerosis or a little change on it. Not always, but it can be helpful. And then your sunrise. If you see this on here, you want to go ahead and get an MRI to determine the stability. So when you have an open physeal kid with a stable lesion, those have a great chance of healing non-operatively because that blood supply is very, it's really high. If you just decrease the irritation and stop the trauma, the microtrauma, oftentimes they will heal. I treat these in a post-op hinge knee brace, locking them so they can bend to 30 but not beyond. Just allows them to have a little motion and not get stiff, but I also use crutches. And I make them non-weight bearing or toe touch weight bearing for 4 to 6 weeks. That a little bit depends on their age, when we've caught the lesion, and how compliant they are as well. And oftentimes at 6 weeks, you can repeat an x-ray. You may not see significant change, but you certainly don't want to see worsening. We'll start physical therapy to start regaining their strength and their motion and slowly progress them back to activity over about 3 months. Most of these heal without fragmentation. ones that don't heal or that are a little bit older in age, you have to have a really kind of low threshold to repeat imaging and to refer them for surgical consideration. In fact, I had a kid that had bilateral stable lesions treated, did very well, but never fully healed them, but was asymptomatic and doing well. And 3 years later, I just checked today, actually, he just had his second knee operated on. His other one was done a year ago. So he went on to not heal, but he started treatment at 13. Or actually, I guess it was 12 because he's now 15. And it's about 3 years difference in between. So you do need to follow them. And we followed him closely. He was asymptomatic until about a year ago when he became symptomatic again. And it just showed they weren't going to heal. So the best non-op prognosis are open distal femoral physes, the younger age. So that kid happened to be 12, a little older. The location. And then poor predictors if you already see sclerosis on X-ray or if there's that synovial fluid under the bone on MRI. Switching to the elbow. So you have an 11-year-old baseball pitcher with acute onset right elbow pain. He trained all winter, batting, pitching, no problem, started spring ball and played with minimal pain. Just gets sore after games sometimes. He played a tournament this past weekend, had pain after throwing. By the third inning, he had pain with throwing that limited his speed. He pulled himself, iced, rested, and he's a little sore today. This is a classic story for somebody that comes in with, medial elbow pain and an open growth plate. We're thinking medial epicondylar apophysitis or little league elbow. It's recurrent stress on that medial elbow. In an older person, you might see a UCL strain or injury. But with this open growth plate, you've really got to think of a stress fracture or a loading of that apophyseal plate and a stress injury to the apophysis. So it's most common in throwing adolescent athletes, and we see it when they increase or like they kind of step up a level. You also see it in kids that are kind of bigger than the maturity level. So a kid that is, tall and heavy, but is really still Tanner stage 1, not really going through much puberty. And so they're in a very active state of growth. It can also occur in any other sport with repetitive valgus stress, but we just see it most in throwing athletes. Generally, they're going to have pain during and after throwing that improves with rest, and that's what gets them. They throw, they take a week off, they feel better, they get through maybe a game or two, it hurts, they take a week off. And so it becomes more of a chronic injury versus an acute injury. The longer they have it, the longer it takes to heal. I love in a story that I just presented when they come in, a day or two later, because they're going to get better sooner than someone that's played through it for 3 months. Typically, they don't come, though, until they feel weakness, decreased accuracy, or decreased velocity. A key aspect of this is that there is no joint effusion, and you may not see any changes on X-ray. This looks a little widened, but is it? We could check contralateral X-rays to see, because if the widening is there, we know that's where it is. But this, left-hand side, it could be an irritation of the growth plate just early on without widening. I don't typically get an MRI unless they are showing, not improving with rest. But then when you get the MRI, you'll see that there's inflammation, edema in the apophysis as well as in the medial epicondyle. So treatment for this it's frustrating. These kids, it's really hard because they don't have rest. They don't have pain when they rest. And I tell them, I don't care if you have pain or not. I want 0 throwing, not to a 1-year-old, no throwing for at least 3 weeks. I see them back at 3 weeks. I make sure they're non-painful on exam, that they are non-painful at rest. If they have been pain-free, I let them bat. Usually I'll tell them give it a week, and then if you have no pain, you can go ahead and bat. But if they're having pain at rest or with everyday activities, they should not be batting. Also, many other sports don't hurt while you're doing it. So you might be able to play, basketball or a different sport that doesn't involve throwing. Very important the minute you see them to get them into physical therapy. Generally, this problem is not an elbow problem. Yes, they're presenting with a injury to the elbow, but typically it's because of poor core strength, poor scapular control, shoulder issues. So we really want to address the whole kinetic chain and look for the imbalances. Again, this often happens in kids as they're going through growth spurts, so their bones are growing, their muscles are adjusting afterwards, and so they're in a constant state of imbalance, and they're changing their technique. So the earlier we start it, the better luck we're going to have. But the key thing here is do not throw through pain. We're going to go through some return to throw after I go through the next thing. So another presentation could be the same kid, 11-year-old comes in, sorry, could be a 9-year-old comes in throwing, elbow pain, but the difference is their pain is more lateral. Then we're thinking, okay, well, we've still got that valgus stress. It's still pulling on the medial apophysis, but their pain is lateral. And we get an x-ray and we see that they have sort of a fluffy appearance of their capitellum. This is osteochondrosis of the capitellum. It's named Panner's syndrome, and it's from that overloading of the joint. It can cause loss of motion, stiffness, and it has swelling of the joint, different than the medial apophysitis that does not. Typically, I will get an MRI of these to differentiate whether it's an osteochondritis dissecans or if it is Panner's. So on Panner's, we're seeing sort of a diffuse edema and generalized change due to loss of blood supply to the condyle. And so the key for this is decrease load on that elbow. Let the elbow heal itself. Remember, osteochondroses tend to be self-limiting if we take away the stress. So if we give it time, it will heal. Similar to what we do with other areas, rest, healing, but then you can't just go back to activity. You really have to follow them with physical therapy and treat them and a return to throw, which we will talk about. Again, you can also have osteochondritis dissecans, which is more of a specific area that has lost necrosis, so a focal area that may have separation of the articular cartilage and subchondral bone of the capitellum. These are much more difficult because they're typically in the older kid that is closer to complete ossification. So they don't have as much growth left. The blood supply is switching from that juvenile to a more mature form, and they have similar presentation to Panner's. So one of the differentiating is age, and the other is imaging. So we do treat these very similarly. However, you want to look for stability. So again, you want to make sure that there's no underlying fluid, that there's no loose fragment, there's no sclerosis there, because those are things that are going to lead to poor healing. Also, the age. The older they are, the less likely they're going to heal. I typically am very aggressive with getting these to a surgical evaluation, and follow them very closely with a slow return. I want the surgeon involved because when that becomes unstable or if I see it not healing, I want them to kind of know what's going on. It just depends who you work with and what your communication is with your surgeons. Because typically I will start these non-operatively if they are stable, but just with close follow-up. So same 11-year-old baseball pitcher comes in with acute onset right shoulder pain, kind of similar history to elbow pain. So on exam, he has pretty normal looking tenderness to the proximal humerus, has full range of motion of both shoulders, but has some loss of internal rotation when in abduction to 90 degrees. So typically we'll see pictures. Younger kids may not have adjusted as much as, the longer you are in pitching, you might get a little bit further extension in external rotation. But what we don't want to lose is that full arc. You don't want to see a more than 20-degree difference from right to left or dominant to non-dominant. And you definitely want to make sure that they're going, further down than 0, kind of closer to 60 in terms of internal rotation. Again, this kiddo had some weakness on empty can and resisted internal and external rotation, scapular winging with wall push-ups. So, scapular function isn't going great, normal x-ray. So this kiddo is diagnosed with proximal humeral epiphysiolysis with glenohumeral internal rotation deficit, or GERD. Very important to identify that GERD because you can treat this all you want, but when they go back, if you haven't treated the problem, you're gonna set him up just to be right back to where he was. The other thing that we found on exam was some scapular winging. So again, the problem might be in the proximal humeral epiphysis, but it actually is due to mechanical issues in the shoulder function with the scapular, dysfunction and the loss of internal rotation. So just because they have a normal X-ray does not mean that they don't have this problem. A clinical diagnosis is kind of the starting point. I again put them 3 weeks complete rest, and if they're not improving, I might have them rest longer. By 6 weeks, I'm going ahead and getting an X-ray. One of the things you want to make sure you look at is before you send them back to throwing, that they go through their physical therapy, they improve their biomechanical issues, and then you want to look at their throwing mechanics. These kids, again, are going through changes, so they're not going to have a full, perfect biomechanical throw. A lot of times they may not open up their hips adequately enough. They may be using their arm more than their hips to generate power. So really just getting somebody to look at their throwing, making sure their mechanics are somewhat adequate and trying to improve them. But no matter what we do, the reason this injury happens is there's a rotational force on that proximal humerus, and that physis is not designed to take that rotational force. That torque is huge, and the repetition is what damages the physis. So when we're getting them back to return to play, we want to make sure that they are ready. We want to make sure that they have gone through their physical therapy, that they're not having pain at rest or not having pain with their physical therapy exercises. We've evaluated their throwing mechanics, and that we're going to guide them through a progressive return to throw. That there are lots of different versions of them. Most of them start with light distance, light intensity, short distance. You increase the intensity, and then you increase the distance, and then you kind of stepstone like that. It's easier to get back to position play than pitching. And it's really important that you look at their length of injury and the length of timeout to determine if you're going to use a shorter or longer return. And in general, the younger they are, the slower I am to return them. I might have them do every other day or every third day return to throw, but rarely do I have them progress daily. So a lot of talk is put into Little League pitch counts. These are kind of older studies, but they are very interesting. If you look at the pitch count and you exceed the pitch count, 11% of the kids made it of Little League World Series pitchers played in the majors, whereas pitch counts were followed, only 10% played. But if they exceeded the pitch count, 50% of them had an ulnar collateral ligament reconstruction because they had breakdown of their ulnar collateral ligament. Whereas if the pitch count was followed, only 2% went on to have ulnar collateral. So what we're doing in the pediatric age group has a great effect on how they are going to survive playing later. And I think that's really, really important for kids to understand because they just want to play now. But anyone that really wants to go on and play, it adds up. So another study showed that pitching more than 100 innings per year, you were 3.5 times more likely to be injured. So it's really important to follow your pitch count, diversify your positions and skill training. And really, you need to think about the age, the strength, the size, and the skill. But you got to not just look at the number, you got to look at the pubertal age, because sometimes these kids are going through crazy growth spurts. You might have a 14-year-old that looks like they're an adult, and you might have a 14-year-old that looks like they're 10. So be mindful of their pubertal stage. And then encourage rest from sport 3 to 4 months per year. That's a good guideline for all sports, but particularly from pitching. So we're going to switch into the last section, which is the hip. Everywhere we look in the body of a kid, there's a growth plate somewhere. The hip, there are lots of them. You've got anywhere you have a tendon attached, you're going to have an apophysis. So you've got multiple hip flexors, your hamstrings, and all these others that can have dramatic traction effect and can injure in their areas. So this is mostly a disease of adolescence, and it's really an explosive type sports, jumping, sprinting, kicking. In general, if they're displaced less than 2 centimeters avulsed, you are good. Anything more than 2 centimeters, that should be at least discussed whether surgical repair is necessary. So on the hip exam, this is really one where you just have to know your anatomy and feel and figure out where it hurts. Oftentimes I'll have people come in and say, "Where do you hurt?" and point there. And then I start pushing around, and you can also activate the muscle. So, for example, if you have them elevate their leg, kind of closer to 60 degrees in hip flexion and resist, you're going to check a little bit more of a rectus. Whereas if it's a lower, like a 20-degree flexion, you're checking more the iliopsoas. If you have them more sort of bringing their leg out and you're resisting it, you're getting more the sartorius. Pubic symphysis, you really got to push right on there. I actually saw a kid with a adductor strain pubic symphysis injury today, and he had seen someone before, but no one had pushed on him. And when you push on his adductor origin, it's really not that bad. But when I pushed on his pubic symphysis, that's where he hurts. And he wasn't afraid to say it, and he wasn't embarrassed to have me push there because he was really happy that finally someone said, kind of what's going on. And so we have to be mindful of just getting in there and pushing where we need to push, or having them activate the muscles they need to activate. So why is it important? Well, it's really hard to get off your hip, and these are injuries that you do not want to play through. These are basically, whether it's fully avulsed off, meaning displaced, or if it's non-displaced, these are essentially avulsion fractures of the pelvis. And so you want to treat them as fractures, and you want to have the athlete understand the importance of allowing healing time to occur, which typically takes 3 to 4 weeks of complete rest to get it to calm down. Now, if somebody comes in and they have pain, but they don't have any changes on their x-ray, and it's been going on for a little while, it might be more chronic, they might be able to get back to play a little bit sooner. But somebody comes in with a displaced fragment, I'm telling them it's going to be 3 or 4 months before they're back, because that is just it, healing time, and then there's downtime. And so then they have to get their rehab to get their strength back. These are big injuries and often lead to a lot of time out of sport. So an example, a 16-year-old male presents with acute onset left buttock pain after jumping hurdles in track. Difficulty walking, x-ray reveals avulsion fractures of ischial tuberosity, which is true of apophyseal avulsion fractures. Well, they're underdiagnosed. If it's obvious like this, people see it. But we've got to keep our eyes open and be cognizant, because the treatment is different. You don't just start stretching and pulling on these. So when we are looking at these, the most important thing is to teach the person that the tendon is pulling on that apophysis, which is pulling on the physis, which is what's, or on the apophysis, excuse me, which is what is injured. Do not stretch. Do not stretch through that tightness. So we have a hamstring injury before. Now we have a 12-year-old female soccer player, sudden onset of right hip pain. She was running, went to kick a ball, felt a sharp pain in the front of her leg, tried to keep playing, but it couldn't play, sat out the game and is limping. So similar, kind of story, different location. Well, could happen in baseball or softball. This is an example of an athlete that I saw at 13. I'm not sure you'll be able to see this. It's a little light on my screen here, but she was batting and came in with an acute apophyseal injury, couldn't walk, was on crutches for a little bit. Actually just came in this past week, and I got a repeat x-ray. And interestingly, you can see that fracture healed, but it's very prominent here, kind of an abnormal prominence. And she now has a hip flexor strain. It's not an apophyseal injury, but it's important to recognize when it is an apophysis, because the treatment is different, right? Rest to let the fracture heal, rehab to get them back, slow progression to sport. Whereas a muscle or a tendon strain, we can treat more aggressively with physical therapy, activity modification, cross-training. So on the imaging, we really want to make sure that we are looking at specifically at these growth centers. This one isn't very obvious that it's pulled apart, but that's right where the patient is tender. So with slight widening, tenderness, difficulty lifting the leg up, they've got an anterior superior iliac spine injury. So treatment for these depends on the disability. So the softball pitcher and batter that came in when she was 13, she was put on crutches. She couldn't even lift her leg. So I actually tried to put her into a hip spica splint. She ended up buying a neoprene one that kind of helped support it a little. But generally for the first week or so, they're pretty miserable. So you're not having them use crutches and lifting their leg up. It's toe touch because they can't lift their leg up, but just getting the weight off of it. And then I'm quick to get them into PT. Again, do not stretch. The difficult thing with these is that they take so long to get back to game ready condition because it's a fracture to that growth plate. So the rest is allowing the healing, but then you got to get them back to strength and get them back to full sort of mental readiness and physical readiness. While they are doing this, I want to tell them what they can do. So if it's their hip, it's really hard. They can't do sit-ups, but they might be able to do a plank, which is an isometric hold of the muscles. They might be able to do upper body conditioning. They might be able to get into a pool and swim with something between their legs so they're not kicking. But the most important thing is that they do not push through their pain and they do not return too soon, because once they start having that recurrence, it becomes more of a chronic injury. You don't have the same response to healing, and it's just a vicious cycle. So this is a 13-year-old boy who comes in with 3-month history of knee pain, thigh, groin pain, significant increase of pain over the past week. Most of the pain is tolerable. He can walk, but no history to suggest endocrine disorder and nothing on physical exam to suggest that. So what is the diagnosis? Well, this is SCFE. It's a skip capital femoral epiphysis. So it's a chronic, often a chronic or gradual slippage of that physeal plate of the proximal femur. It's kind of like ice cream falling off the cone. And what happens is it gradually happens. If it happens acutely, great, catch them. Don't let them leave your office, send them to a surgeon. But oftentimes it happens gradually and they come in, and if you're not, thinking about it and they're complaining of knee pain and you don't get a hip x-ray or you don't do a hip exam, you might miss this. So you really want to, always examine the hip when you have somebody come in for knee pain. Also, oftentimes when they're laying on the table, they're going to have an externally rotated foot. It might be a little bit longer than the other one. So I'm sorry, the affected one will be a little bit shorter, but it'll be externally rotated. And so making sure you get an appropriate x-ray. The key factor of this is a surgical treatment, and it can be bilateral in 20 to 40%. So you want to make sure that you send them directly to the ER. You don't have them go home, have them go be admitted for surgical treatment. Oftentimes we'll get labs to look up to see whether there's endocrine disorder, because if there is, they're going to treat bilaterally. Also, the younger they are, the more likely they're going to treat bilaterally. So if they have open triradiate cartilage, which this one does here, you're going to treat it bilaterally. There's that triradiate cartilage. The last one we're going to talk about is a gymnast wrist. So oftentimes you'll see kids that come in, their wrist hurts. It's very non-specific. If it's a gymnast, you might first consider, okay, well, you're using your body a lot. It's basically a weight-bearing joint, even though it's not designed to be that. And so that repetitive stress causes physeal inflammation and changes within that distal radius physes. Early on, you might not see anything, but as it goes on, you might start seeing some widening or some changes in that physeal plate. You might see swelling. You might see cysts in the x-ray. But as it goes on, you might have early closing of that physeal plate, which causes the radius to stop growing and allows the ulna to overgrow. And then there becomes a positive ulnar variance, which can lead to a lot of pain issues down the road. So it's very important to recognize this and treat it before it gets too late. Treatment is rest with a brace. I oftentimes cast these kids because they don't want to stop. With the introduction of exos, the moldable, removable fracture braces, It's really nice to use those because it holds them really well and it's stable, but you either have to lock it or really know that they're going to be compliant. It's nice because then they can take it off to bathe, but they should really have it on all times. You want to take away the weight bearing on it, but you also just want to give it the physes complete rest. So I think the message that we need to take home is keep our eyes open. Not all, injuries are what they seem. And especially in kids, there's lots of areas that we need to consider outside of the typical ones. And always think of a growth plate. That's the first thing you should think of as somebody's young and has open growth plates. And we really want to stop these acute injuries from being chronic. We got to stop that. I use this phrase multiple times a day. If you had a headache and you hit your head with a hammer, would your headache go away? No. We've got to stop the hammer. We've got to get them to understand the importance of, resting periodically from their sport, making sure they're using proper mechanics, making sure they're following pitch counts, and that they're, being respectful of times of growth and that they're not pushing their body beyond the physiological ability. So a couple of questions. So 12-year-old gymnast presents with right wrist pain. Pain has been progressive over the past 6 weeks. Swollen, tender on the dorsum of the wrist. Pain is worse on the floor and vault, but she can do bars with minimal pain. What is the most likely diagnosis? Well, we see 12-year-old, we're gonna guess that she's probably got open growth plates. But this is a bad board question because we don't know what her Tanner stage is. We don't know if her growth plates are open or closed. So the most likely diagnosis in a 12-year-old is distal radial epiphysiolysis, which is gymnast wrist. But if she had her period at 9 and she's done growing, it could be a wrist sprain. So 12-year-old male basketball player presents with right knee pain, worse with running, jumping, and improves with rest, occasional catching sensation. Physical exam is significant for pain on inflection on the right, pain on end flexion on the right, a right knee joint effusion, positive tenderness to palpation of distal patella tendon by insertion bilaterally, but no pain with resisted extension. AP and lateral x-rays are below. What is the next best step? So we've got pain on deep flexion, joint effusion, tibial tubercle tenderness. So I hear joint effusion, tibial tubercle tenderness. I want to make sure, is there an avulsion fracture there? Doesn't look like it. That looks pretty intact, but we'll see. No pain on resisted extension, probably not a tubercle fracture. But what else am I missing? I don't have proper views, right? So we want to get a tunnel view to make sure that we can see whether or not there's an osteochondral dissecant or osteochondral defect. Oh, that's wrong. I don't know why that's in there. I don't know why that went big. So you can see when this is actually the same person in AP view and then a bent view, the notch view, and you can see that there is an osteochondral defect there. If you didn't get this view, you would have missed that. So that's that, and I'm happy to take any questions.
Thank you very much, Dr. Goldberg, for that awesome and wonderful review of pediatrics overuse injury. Please feel free to ask any questions and add it to the chat. We'll give it a few more minutes and we'll take it from there.